week, Surfing the MASH Tsunami brings you 3 major stories from the world of steatotic liver disease. This weekend, we're bringing you each of these stories separately so you can listen over a shorter, discrete period of time. Hope you enjoy them.
For the last 5 years, MASH-LD stakeholders, whether manufacturers, trial sites, providers, payers, patients, or investors, have turned to surfing the MASH tsunami to keep track of drug and device development, epidemiology, public health initiatives, and practice patterns. This weekend, we are sharing the 3 main sections from our episode 9. Roger will provide more information after these notes from our sponsors.
Surfing the MASH Tsunami is sponsored by these healthcare-related organizations.
Regeneron is a leading biotechnology company that invents, develops, and commercializes life-transforming medicines for serious diseases. Founded and led by physician scientists, their unique ability to repeatedly translate science into medicine has led to numerous approved treatments and product candidates in development, most of which were homegrown in their laboratories. They are shaping the next frontier of medicine with data-powered insights from the Regeneron Genetics Center and pioneering genetic medicine platforms, enabling them to identify innovative targets and complementary approaches to potentially treat diseases like obesity and MASH.
LiverRight and the LiverRight Scanning Network. LiverRight is America's first virtual specialty clinic for liver disease, offering adults in all 50 states video appointments and helping GI practices and health systems triage and treat the swelling numbers of patients seeking MASLD and MASH testing. LiverRight offers same-week video visits and accepts insurance. For more information, contact LiverRight. That's liver then R-I-G-H-T as if one word, at www.liverright.com.
Tawazun Health, your partner in global liver health innovation. At Tawazun Health, we specialize in providing small or large-scale access to FibroScan examinations for liver health-focused early detection, clinical trials, independent research, and collaborative projects with clinicians and FibroScan providers, now in over 30 countries around the globe. As industry-leading experts, we design and deliver high-quality FibroScan services because we know that accurate, high-quality, reliable data drives better outcomes. To learn about Tawazun Health or our sister lifestyle app, mylife365.me, click the Tawazun Health link on the Surfing MASH homepage. In this newsmaker conversation, Alexander Krag and Stine Johansson join Roger Green to discuss their recent article in The Lancet, titled Screening for Advanced Liver Disease.
So this week, our newsmaker segment will be with Professor Alexander Krag, a good friend of the podcast, and Stine Johansson, who we've not had on before, but who works with Alexander in Denmark. And we're going to be speaking about a paper that they published last month on taking a look at the various criteria for liver screening and how they might be modified going forward. But before we do this, Stine, do me a favor, since we've not had you on the podcast before, take a minute and just tell our audience a little bit about yourself and what you do and how you got to the work that you do today.
Yeah, thank you. I'm very happy to be here. My name is Stine Johansson. I'm a medical doctor and researcher in Alexander's group. My research mainly focuses on early detection of liver disease and screening. So I'm very happy to be here and talk about screening.
Okay. And just one more thing. If you could tell our audience one thing about you that they wouldn't guess if you didn't tell them.
I know what Alexander would say. That I come from far out in the country, and Alexander recruited me when I said I knew how to drive a harvester.
Okay. You know what? That's different. Thank you. That works really well. So why don't you hop on your harvester, and Alexander, you can hop on your John Deere, and we'll do this interview while we're tooling around the fields together. How's that sound?
That sounds wonderful.
Okay, great. So then one more thing before we start Groundbreaker. One good thing that's happened in each of our lives in the past week. Brave one, go first.
I think it's the same, you know. I'm so happy and proud by my researchers. But this week, Stine actually was awarded a prize, a talent prize for young researchers, you know, across the country. They give across discipline prizes for people below 30 who done extraordinary research-wise. So I think that was a great thing to have actually given opportunity for talent who made it so far so young.
Well, okay, so congratulations, Stine. And since
Thank you. Yeah.
Is that yours, or do you have another one to go with that one? That's a lot.
I think it's...
Yeah. We'll leave that there. Mine, I guess, is just, gosh, I'm looking forward to Paris next week. And it's just been an exciting month with a lot of news in liver disease, right? I mean, if you think about it, in the last month, we've had the EMA approval of resmetirom, the U.S. approval of semaglutide, and the FDA paper on NITs, all of which we're trying to get covered in appropriate time. But this isn't that, although this is related to all that. This is a rather fantastic paper. Let me just tell our audience, we tried to record this episode before, and my power did not work. And as a result, we had to stop in the middle, and then we all went on vacation, and so we came back a couple of weeks later, and here we are. But this is a paper that published in The Lancet in the September 25 issue, and the title of the paper is Screening for Advanced Steatotic Liver Disease. But I'd love for one of you to start our conversation by talking about how you came to decide that it was a good time to review criteria that had held up, I guess, since 1960, and what it was that motivated you particularly to go back into these criteria at this moment.
I don't know, maybe I can start there. As you say, the field is moving. We got new drugs. We've got a lot of work around non-invasive tests. We're discussing healthcare pathways, opportunities, changes. But we also know that the patients are hidden out there in society. To have successful treatment, you need to find them asymptomatic stages. And therefore, it has in recent years been more and more discussion around screening. And at first sight, screening sounds wonderful. Let's find something. Check everybody. Nobody will be missed. Nobody will be left behind. We can save everybody. But that's basically not the truth. Sometimes we need to dissect it, understand it, and assess it. So we thought it would be a good time to see, okay, if we take the strictest criteria, because we don't need to convince ourselves here. We love the liver. We need to convince those who actually pay for it and those who want a screening test that this is a good idea. And in the end, we also need that circulating into improved health outcomes. So that journey is long and hard and difficult. So we took this challenge upon us and try to see what does it look when we look in the mirror and say exactly what we see.
Exactly, yeah. The goal of screening is to find those who appear to be healthy. They don't have any symptoms, but in fact they do have an early stage of the disease. So as Alexander says, it sounds very admirable, but perhaps it's not the whole truth. We need to look closer into this.
So when you say admirable, what about it sounds admirable that isn't? And what is it about it sounds admirable? Let's start first. What makes it admirable? And then what about it sounds admirable but isn't really when you look under the covers?
Yes, as Alexander says, if we can find people, if we can use screening to shift the paradigm from treating decompensated cirrhosis to instead find patients earlier and avoid altogether that they develop symptoms, that they get sick, that they die from their liver disease. That sounds very good. That's the admirable part of it. But in fact, most who participate in the screening program, they don't benefit from screening, and some even experience harm. So we need to put it all together when we take the decision.
So please elaborate. When they become part of the screening process, what is it that leads them not to benefit? And on the occasions that people actually experience harm, what is it that makes that happen?
So when participating in a screening program, there might be false positives. There might also be false negatives. And there might be overdiagnosis and there might be overtreatment. So the false positive part could be a patient has been told, okay, we took this test and we have shown you have liver disease. So now this patient thinks, I have liver disease, and that might cause some psychological distress. It might cause anxiety. It might also cause further testing. In the case of liver disease, it might be perhaps even a liver biopsy, and that liver biopsy might lead to some complications. So for this patient, they have experienced all of the disadvantages of screening unnecessary. So that could be one example. Also, some patients are slow progressors. They might never actually progress to decompensated cirrhosis. Perhaps in the end, they would die of something else. But having found a lot earlier, okay, you have liver disease, it might cause that stress, even though if we hadn't done screening, we would never have found those patients, and it would never be a stress factor.
Yeah, add to it. So I fully agree. That's the false positive signs, basically telling people they're sick when they're not. And that's not very good. And then the other side is the false negative side. We go out, the admirable thing is that exactly we can go find everybody, leave nobody behind. When we see patients, I have my outpatient clinic tomorrow. I'll see patients. I wished I've seen them 15 years ago, because then they would not have decompensated cirrhosis and wait for a transplant or something else. So the question is basically, do we have tools? Do we have a system that would allow that to happen? And the truth is basically with the biomarkers we have now is that if you go out in the population, and let's say you maybe have a few percent, maximum 5%, depending on how many risk factors that have liver disease. So that means that 95% will not have anything. So if you go out with a test, the test will not do very well. And the problem, for instance, for the FIB4 We're all pushing that. It's kind of the best and the cheapest we have that. But that leaves, that's a sad number, 50% behind. So that's probably not a good system. And the day we called in to the hospital to pay us and say, okay, Alexander, you're a smart guy, you done all this. Tell me, what is the cost benefit of this? And I have to say that 50% are left behind, etc. But also seems there are some false positives. My colleague would say, okay, we're already very busy. Healthcare systems are under pressure. We have a shortage of healthcare personnel and resources. How much of this should we use to potentially healthy people? So that's the challenge. That's the answers we need to come up with as academics and liver advocates to circumvent or convince a system that we should do this. And then there are many also things we can maybe get back to that, the practicalities. Will people show up for the system? That's another thing. This is a volunteer. This is real people out there. They are busy. Do they know enough about the liver? Well, they show up. Let's say they go for the index testing. How many will go for the secondary testing? And there is also data around that we can discuss. So that's the whole thing. It sounds like an easy win. The big errands on the way into your turban, saving a lot of lives. And then reality comes where there's a lot of steps we need to understand better and qualify.
Okay. How much of this so on one level, this winds up being a critique or acceptance of the limitations of FIB4, right? It's where we're advised to start. And as you point out, it's not very good.
So again, we are not here to judge. We put forward the data and say, okay, listen here, guys. If FIB4 is applied, it's a reality that it have a high negative predictive value. That's right. But that's sort of the nature when you are fishing in a dam with very few fishes you're interested in. But that tells us that the performance of this test. So it's not critique. It's just that we will be faced with this when the systems ask us, how well is it? Just like for any other screening program, how good is the test? And that's part of these criteria. We need to go through that. But maybe you can expand on the FIB4 and the test, Stine, because this is, of course, very, very important for the success of such a system.
And in the perfect world, the screening test, perhaps because it's so low prevalent testing, we need perhaps hierarchical testing. So it might be a two-tier test. And in the perfect world, the first tier test would be widely accessible, it would be inexpensive, and it would have a high sensitivity. But we're not sure we have that test yet.
When you say we're not sure we have that test yet, I think you're being kind to the test. But yeah, I take your point.
You have to also be realistic. FIB4, what was it developed for? That's more than 20 years ago. It was used in secondary tertiary testing to assess fibrosis in patients with hepatitis C. And now we try to apply it to a different setting, and that changes the performance of the test. The good news is that there are many other tests coming up because people understand this. We just need to have a test that's simple and again have these criteria, as Tina said, with a high sensitivity, so we can rule out people, but without leaving people behind. And that's a trade-off when you do the math of finding what is the cutoff that's most optimal for doing exactly what you want. And that's why this is rarely you get that with one test. And that's why most screening setting have an index test exactly with high sensitivity, basically ruling out. And then you have a secondary test with high specificity, sort of to rule in disease. And then you got a better capture. And then the whole thing is also what we are learning better now. What is the prevalence of liver disease in the general population? So maybe, Stine, a little bit about what is the pre-test probability? That means the test, just if you look out there in people who are lean, who don't have type 2 diabetes, who don't drink, versus somebody with well-characterized risk factors. The pretest probability in patients with people without any risk factors is very, very low. And that's also why the current guidelines, and I think they're right, and that's at least the stage where we are now, recommend screening in more or less patients with type 2 diabetes, or high alcohol consumption, or some other characteristics where we know the dam we are fishing in, there are more fish that are relevant for us. And there's actually one screening study done in Sweden from where they put the liver screening on top of one of the diabetes test systems. I don't know, Stephen, if you want to mention that or want me to go through it. No, but it was from Hannes Hagström and his group, and I think it was brilliant to see, because we cannot do liver screening alone. We'll not make you, and then we can have 50 different screening programs. So they added to type 2 diabetes. It makes good sense. The interesting thing was that even if they find the highest FIB4, it was, I think, around 60% only who wanted to have the next test. So the awareness, and the same we saw in the SEAL study they did in Germany, also a relatively big proportion of the patient didn't ask for secondary testing. So that's about the awareness, what you are doing, what we're trying to do, that people should actually care about the liver like they care for their heart, the lungs, or something. But also that some of the tools we have didn't perform that well.
Yeah, and also another a randomized control trial performed in Hong Kong and Malaysia. It was in patients with type 2 diabetes, and they were randomized for either standard of care or to automated non-invasive liver tests. And of those patients with increased non-invasive tests, only a third of those who were supposed to be referred actually went to further assessments. So that just shows if only a third show up for further testing, it's not feasible to do screening. And there could be many reasons for why only a third show up, but it's not feasible anymore if people don't want to participate or can't or whatever the reason is.
So let's go to the question of don't want to versus can't for a moment. This is one of the things that this paper talks about is the need to provide social equity, make sure that this is equally available to people regardless of where they live or what their income status is or any of that. I would assume that's about the can't side of the won't or can't. Well, maybe both, but certainly the can't side of the won't or can't. The question is, how much can we improve or reduce the number of people who won't simply by providing better education about this disease, which has been woefully lacking forever, really? So how much of that can we improve with education, and how much of that is about other factors?
I don't know if I can open it up, because it's very well known from any screening programs, and also the effectiveness. That's basically about the effectiveness when you go out in the real world. You might have data from randomized trial when you come out. And for instance, there are things about healthy volunteer bias or who goes to the screening program. That would be people like us, well educated, but probably with a very low pretest probability. And that's a problem for any disease. The more marginalized group, the less educated or socioeconomic, more challenged groups, where the disease prevalence of these are just higher, they have lower awareness. These are notoriously not having a low adherence to these. So this is very, very difficult. I don't know if you have reflections on how to overcome this, or why is it so?
Yeah, or at least like if we were to implement a screening study, this should be something that should be evaluated afterwards. We need to see data. Okay, does this work? Do our setup work? Are there some certain people who don't participate in screening? So this should continuously be evaluated.
And I think there one thing you could speculate, because what is the reason many of these people don't come? That's of course because they might not know it, or they don't trust so much in the system, or they've always felt stigmatized. We know that, of course, around obesity, alcohol. They don't trust people like me very much, of the system I represent, basically. So how can we bring the test closer to the patients, where they are, where they live? That has been some of these things that can improve health equality. And yet, I think I'm a bit, again, worried when you see this relatively low adherence. And now we have also the data of the liver screen score we are looking at now. And again, it's more or less the same, that a surprisingly high number of patients or people, even when we find a positive high liver stiffness, that don't show up for the secondary assessment. And that's, of course, of implementation. That's a problem that can probably be solved. But even you can see the best program for cancer screening programs, I think they are probably in the range of 70, 80%, something like that. So you will never get to 100%. And that also means that the day you do the math and see how effective is the screening, really to reduce the burden of this disease, it's challenged. And that's also why no screening program reduces overall mortality in society. They might reduce disease-specific mortality, but not overall mortality. So it's still, it's a challenging and yet very appealing thing. And that's why we are doing and spending this time and on it, and have got these massive projects with Liver Screen and Liver Aim, where we're trying to do exactly this. But as researchers, we also have to be honest. Sometimes when you open a door or you look into things, you don't always find what you wish to find. And there, our responsibility as academics is to tell the truth, to be honest.
And also following up on Alexander's, so in this paper, we try to build the case around the Wilson and Jungner criteria. Should we screen for liver disease in the future? But we also put on additional criteria. So thinking of, okay, in today's world, what else should be considered? Are there criteria we should add on? And especially for steatotic liver disease in this case. And one thing that we argument for is that we need large randomized controlled trials, sufficiently powered with hard endpoints. So with the decision whether to screen or not needs to be based on data showing that screening for steatotic liver disease reduces morbidity and mortality.
Maybe just an extension. I don't know, right? If I can just give an example how challenging it could be. I served in the EASL governing board, was very interested in public health and trying to see how we can make some of these things. And all guidelines around the world suggest screening for hepatocellular carcinoma in patients with cirrhosis. And there was the European Beat Cancer Plan, a very, very big program run by the European Union, trying to push all cancers, including a lot of funding, and liver cancer were not there. And we were trying to push it in, and also for having it recommended as a screening thing. What we were met with all the time, and we never won, was to show us one randomized trial where screening for hepatocellular carcinoma sort of approved to improve health outcomes. So that's, again, we should be realistic and see, okay, how do we win that? And that's example. I think it should be pretty easy win. We all believe, we think it is so, it's done. And yet, if you don't consider those on the other, or let's say those as kind of a gatekeeper to unfold this at society level, we are likely to be disappointed.
So we've got new criteria that say we need better trials, better, bigger trials. Okay. How long will it take, do you think, before we have those trials?
It will take a long time because we also need hard endpoints. And those hard endpoints will not happen it will happen in 10 years, perhaps. So it will take a long time.
Dina, you have to explain about LiverAIM. We're responsible for that trial, and you are our boots on the ground. You have to explain that trial, how ambitious it is, but we need to be a bit patient.
Please, I was between the two of you, either beat me to the next question or the next topic. You're fantastic. Stina, go ahead. Let's talk about LiverAIM a little bit.
Yes, in LiverAIM, we are doing a very large randomized trial on screening. So we aim to do a randomized screening trial. So it will be screening for liver disease coupled to intervention. And we will include 100,000 patients and randomize them to either standard of care, so no intervention at all, and the other 50,000, they will be screened for liver disease. So first a screening test and then a diagnostic test, and then we will also intervene against the risk factors. So if they have an increased liver stiffness measurement, we will try to reduce the risk factors for liver disease. So that's the entire study, 100,000 participants in the screening trial. And then we will assess outcomes. Did we reduce morbidity and mortality in relation to liver disease after 10 years? So that study will be done in 13 years, 14 years.
The full study, of course, there will be reports in between, but that's basically the level of ambition, because this is a relatively slow progressing disease. So finding clinical outcomes in terms of reduced number of liver-related events or decompensated transplant, death, etc., takes a while.
One clear point is that a lot of times on this podcast and elsewhere, we talk about liver as part of the entire metabolic cascade of diseases. For example, people with MASH are more likely to die of heart disease or complications of diabetes than they are to die of liver cancer per se, or cirrhosis. This looks at only the liver-related, if I understand correctly, we're looking only now at the liver-related consequences of MASH, not at the metabolic effects per se.
That's a really good point, because when we intervene against the risk factors, against overuse of alcohol or overweight or type 2 diabetes, when we intervene against those risk factors, it will also improve, hopefully, health outcomes of cardiovascular disease or perhaps cancer. So it's, of course, also important to register those outcomes after 10 years and see, is it health screening overall?
And is it diluted in, as you say, cardiovascular or cancer signal? We don't really know. And that's the knowledge we need. But I think another thing is also, how do you want to deploy it? How should it be? And I think it's important to see people, in particular, say the more challenged group that are notoriously not doing this, they cannot, let's say they're in their 60s or something, be in 10 different screening programs. That will never work. So it needs to be something where this is integrated in the way we manage or screen for other cancers. It could be colorectal cancer for females, breast cancer, something like that, where people are anywhere already there. And then this is added on if we should have a meaningful uptake, I think.
That was actually an example, like screening for colorectal cancer in many countries, it's a fecal sample. And that might also cause that some patients don't want to participate in it, because overcoming that barrier of doing the fecal sample, that's too much. So that would mean for some not to participate in that screening program.
Okay, interesting. I'm mindful of the original work that Stephen Harrison did in San Antonio, where they took people who were simply getting colorectal screens, right? And they were there for colorectal endoscopy, just basic screens, asked if they wanted to be tested for liver at the same time using FibroScan, and found that, 37% of them had MASH, 37% had MASH-ville, somewhere in the high teens had MASH, somewhere in the mid-single digits had advanced fibrosis, right? So that would be not an example of how to do a cancer screen, maybe, but how to do MASH screen. This is different, yeah?
Yeah, no, I think that was the same trick that they did in Sweden, tried to go it together with, let's say, annual patient diabetes control or something. Where do you add it onto something else? And then you people to sign off it. And I don't know, indeed, kind of remember Stephen's study that much in detail, but then what was surprising in some of these studies is also that people, despite that they might have an elevated FIB4 or an elevated transient elastography, don't show up for the referral to a hepatologist. And that's, again, there is these attritions in any steps in the systems. It's difficult for us to understand why that is, but it's just the reality. And of course, every time there you lose people, and thereby losing effectiveness of a screening program. And then there's a back to, I think, Stine, you already alluded a little bit to it, the same in a cancer screening program. Because which cancers is it you find if you go for regular interval? These are often the less aggressive cancers, because the cancers that are very aggressive, they emerge in between the screening programs. That's the fast progressors. And it could be, depending on how this is in the system, is that we will never capture it all. So how can we actually find those, or have a test that is already able to see which one of the more aggressive one and which one are less? And that's, again, back to the effectiveness of the whole biomarker or healthcare trajectory we have for the system. So it's not to be negative here. It's just that one thing is go for targeting screening of patients with risk factors, but population-based screening is simply a different beast.
Yeah, with different goals. And the other point which you make is that in liver disease, right, 80% who have MASH-ville will never progress. And some percent of those who will get to MASH will never get to HCC or decompensated cirrhosis. So it's a very different set of goals, yeah?
Yeah, and it progresses relatively slow. The thing about the slow progression will also give us a window to catch the patient. So that's why this is kind of appealing. And probably it's not like aggressive cancers that come in between the screening programs. So it's not that we've given up completely, but I think the evidence we have now, I don't see any healthcare system in the world that will implement population-based screening on this evidence. It simply don't meet the criteria. That's also why we updated the criteria we now call Johansen criteria. There was the Wilson and Jörn, and now it's Stine who, but trying to see with the knowledge we have today, what criteria do we need to meet up front to be successful in having this implemented in the healthcare system?
Okay, so Stine talked about some of that, which has to do with large-scale randomized controlled population trials that might take 10 to 15 years. Can you talk about some of the other criteria that you've added and rationale behind it? Go ahead.
So then the screening programs should also be evaluated afterwards, that we also briefly touched upon. So one thing that might happen afterwards would be public pressure to push towards perhaps broaden the screening eligibility criteria, or perhaps shorten the screening intervals. But that decision should again be based on data. But it would also need evaluation afterwards when if we already have implemented a screening program. So that's one important thing to consider. And also we need to well define the screening population. Is it mass screening? Is it population screening? Is it targeted screening? Should it only be in people with risk factors? How should we do this? It also needs to be based on evidence.
I think also a practical thing. How many resources do you need? How many healthcare professionals? How many rooms will it need? How many sets of FibroScans will it take? So all these simple practical things, how do you actually implement very practical logistics? How do you inform the people? How do you make sure that everybody in society get the information? So some of these things, the logistics around it can also be very demanding. And here, of course, it's not like colorectal screening where you end up with thousands and thousands of colonoscopies, but you could potentially potentially have a lot of referrals to the hospitals. Do you have the capacity to that? Or how do you want to do it? And again, we can be creative. There could be actually, and I'm in favor actually of that, having moving some of the health assessment into the society, because a lot of this could actually be done on Sunday morning when you're out shopping or whatever. So the health comes closer to the people or the patients. We saw that under COVID. The COVID testing could happen everywhere. So what could we learn for that, for bringing healthcare or early detection closer to where people live and thrive, and that they don't always need to come to us in the healthcare system?
So I'm intrigued by criterion number 16 in that context. Screening should only be introduced if all other feasible approaches, including cost-effective primary prevention and optimized treatment within healthcare settings, have been evaluated and found insufficient. How does one deduce that, and do we think that's likely to happen here?
Yeah, that's basically, given all these caveats, we're told that essentially screening is the least effective way. So if you can have other approaches that are much cheaper, that are much easier, and also to document, then you don't need screening.
And is it feasible that we're going to find ourselves here with steatotic liver disease, that the various primary prevention attacks?
No, we know that, as we know, of course, with primary prevention, with the healthcare system, or at least with the politicians we have in Europe, and I'm sure also in the United States, you're not willing to put tax on corn syrup or sugar sweetened this or that or alcohol. So this is very unlikely to happen. That's clear. So I agree. On the contrary, I see with the knowledge we have now and with the data also coming out from liver screen that was presented at EASL, I think the prevalence in the population at large is so low compared to the prevalence in at-risk groups that I personally, at the moment, is pretty critical towards the cost-effectiveness of population-based screening for liver disease. I think they're much lower-hanging fruit, and we should probably start there to how do we actually find the high-risk patient. That would be patients with F3. That's where we can treat with the drugs coming now, and hopefully we'll also soon have drugs with compensated cirrhosis, because these are the ones that critically need some treatment and needs to be catched. And there you have some obvious risk factors: diabetes, overweight, alcohol consumption, and the combination of all. And there, I definitely think we can start.
For the audience, just so everybody's clear, we had Tim Jobson from Predictive Health Intelligence on a couple of episodes ago talking about their experiment in Somerset and the success they had, and things like 66% of the patients they reached out to actually came in. But we're talking about a completely different population here. Those are cases that could take a look at the things that you just identified, Alexander, and say, based on those, we think you're at risk of having liver disease, not HCC, but liver disease, advanced liver disease, and come in for screening. We're not talking about going into a population where it's not clear that anybody, where some people may have no risk factors, because we want to do an overall screen and see what we've got. So I could see that somebody who didn't understand that would listen to some of the things that Tim Jobson said a couple of episodes ago and listen to this and say, gee, those things don't go together. But in fact, it's because the populations are different. This population's a lot broader, and the goal is a lot more limited.
But I think there's always an explanation. If you do things, you have different target population. And that's again back to the prevalence in the population. It makes a big difference. If you go for a population where the prevalence is 0.5% or 2% or 5 or 10%, that's what I always hear. They use this visualization of a fishing pond where you fish, but there's only a certain number of the fish that's relevant for you. But if they're super rare, that no matter what kind of fishing gear you have, it's not going to be easy. The most likely is you find a fish you don't want or not allowed to fish. And that's the whole thing. And then how do you then narrow that down or fishing a different pond? It could be then the patient's diabetes pond or risk factor, very defined by that. Then the ratio of the fish you're interested versus those you are not is completely different. And that gives you a different chance of success. It still means that somebody will left behind, but no matter what we do, some will be left behind. But can we sort of find some of those at highest risk with some initiative? And I think we have to. That's also why we're so interested and spend a lot of time with it. Now we're entering an area where we can actually do something. And of course, the whole drug is not the final solution. We still need, of course, the prevention, primary, secondary, tertiary prevention, because at population level, we cannot manage that with the drugs. It needs to be a combined effort.
We're coming to the end of our time. We could do this for hours. I could do this for hours, because I think you guys have only scratched the surface of what you know about this. But can I ask each of you to just share one more thought on this subject that we haven't touched on that you want to make sure our audience understands?
We should not give up. This is the beginning. or the end of the beginning of screening of the new era of steatotic liver disease. So I think we should be optimistic. And the whole thing about supporting research to develop better markers, but also dissemination awareness of what you do. It makes a big difference if you know and you care about the liver, because 60% signing up for secondary assessment is not very good. And that's a bit sad. That's probably why we're not doing a good enough job of people caring about liver health. So I think this combined effort, we should not be depressed. So we need to continue to do a study and sometimes be honest that they fail. But it does not mean it's a bad idea. It does not mean that the system we have, the tools we have at this stage is simply not powerful enough. And that we need to be honest enough to tell ourselves, okay, this is probably not as we wished it were.
Okay. Stina, please.
Yeah, sure. And I also think it's important that the benefits of screening must outweigh the harms of screening. And we should keep that. We should not be blind to that. It should be in our minds all the time when we assess this.
So this has been great. And we've talked recently in this podcast about all the exciting things that have happened really upstream from HCC. But for the areas where we're making a lot of progress, there are other areas that we aren't really touching yet or aren't able to touch successfully yet. And I guess the point is that this is about using liver aim and other tools to get at some of the population level issues of severe liver disease as they exist today. At the same point that we're now getting systems and drugs online that should do a little better at identifying high-risk patients and getting them care earlier. And those are really in some ways two related but really separate efforts. The detection of the F2 and F3 MASH in patients with multiple risk factors is very, very different than what we're talking about here, which is mass population level screening.
Yes. So that's it. We try to build the case of if we want everybody in, you need to do population screening, mass screening, basically. And the other thing is what you call case finding or selected screening or screening among patients with risk factors. So these are two different things. I think the case for, and even that is challenging, and that's what some of the studies say, that even if you do it among patients with diabetes, it's not such an easy win as we think, at least the first studies. So we need to do more studies and then build the infrastructure around it, how to make a system that's basically effective and cost effective. And also to Stina's point, to see we need also to be honest and see there's always negative sides of it. It could be, of course, directly harm, psychological harm, physical harm, but it could also be financial harm. And we're in a system, a zero-sum game when it comes to financial resources and human resources. So if you lose more people for this, less people for something else, or more than money for this, less for something else. And that's the game the healthcare systems and the payers they look into. And there we need to come with a convincing model if this should be something that will be implemented.
Okay, this has been fantastic, and I could ask 5 more questions and we could just keep going, but maybe we'll save that for the next time I see you folks or the next time we get around. Thank you so much for your time today, both of you. I thought this was just a fantastic and fascinating article in terms of the richness and complexity of you addressed the issue. I thought the new criteria were really fascinating, and thanks so much for taking your time to join us today.
Thank you. Thank you for having us.
Have a nice evening or day.
Bye-bye now.
On behalf of the surfers, our guests, and our sponsors, Regeneron Pharmaceuticals, Liver Right, and Tawazun Health, thanks for joining us this week.
Please join us again next week for a series of roundtables and interviews covering major recent issues in the world of steatotic liver disease.
And until next week, stay safe, surf on, and we'll see you again on Surf and MASH Tsunami Podcast. Bye-bye now.